Okay, it's my pleasure now to introduce Dr. Colin Feeney, and you see his bona fides in the speaker pamphlet. He almost walks on water, but I got to talk to his wife and see if that's true.
Not.
Dr. Feeney, I think you can see what an illustrious career he had when you see his bio. But the big thing about him is his heart. Dr. Feeney has spent his whole life devoted to a community hospital when that probably wasn't quite the thing to do if you're going to be famous and wealthy and all that good stuff.
None of the above.
None of the above. He has recently retired from the Alameda Health Systems, where he was the division chief of the intensive care unit, as well as all those other things. He's been absolutely pivotal and critical to our program, and I appreciate that he can come and speak to us. So this is the slide that shows.
Okay.
Not that one. That's just telling you what's coming up.
Okay.
And it's the big button.
Well, thank you very much. This format's a little difficult for me. I'm used to having a pointer and being able to point at the screen, but they tell me pointer's not going to work on this, and then I have to look at this tiny little screen myself, so forgive me. So this is really the story of how we started acupuncture treatment in a public hospital at Highland Hospital, and how ICM started. So I have no financial conflicts of interest in this. I am on the board of directors, as mentioned, for ICIM, but I have no other financial conflicts. So we're going to talk about the development of this program and describe some of the barriers that existed to creating it, and also talk about a little bit of clinical research that we did in terms of using acupuncture in the ICU. So a few words about me. I was a physician at Highland Hospital for 42 years, director of the ICU there for most of that time, and for some of the last few years also the director of the ICU at San Leandro Hospital, Alameda Hospital, until I retired in 2022. I met Dr. Mateki in 2000. I knew nothing about traditional Chinese medicine. I still know very little, but she started her residency in 2000 and sort of introduced me to this concept. And as you can tell from everybody that's spoken so far, she's very infectious and persuasive, and the rest is history. So I sort of prepared a little review of her CV here, but she's sort of already been through this, so I don't need to, I think, spend more time on this, just that she's eminently qualified in both Western medicine and traditional Chinese medicine. She was a resident at Highland from 2000 to 2003, and we were so impressed with her abilities that she was the chief medical resident from 2003 to 2004. Go back a slide here for a second. Whoops, going the wrong way here, sorry. She introduced the concept to me of bringing traditional Chinese medicine to Highland in 2009. She founded, along with Craig, ICIM in 2010, and then we started clinical services at Highland in 2011. There were a lot of barriers to starting this service. First of all, how do you pay for it? How do you talk the hospital into this? They say, well, we don't have any money. We're the county. We never have any money. In the beginning, this was a free service, and it was an expansion of pain management. So a lot of pain management is done under the Department of Anesthesia, and we could have done that, but Amy's an internist, as am I, and so we said, let's do this under the Department of Internal Medicine, since that's where we have more control. How about space? Where are you going to do this? And Dr. Lynn Berry was critical in helping us get set up in the K6 medical clinics. We already had a primary care medicine clinic, and there was a few open rooms on Thursday morning. And so she said, okay, you can use those rooms, and you can use the existing nursing staff, the MAs, et cetera, and handle this just like we handle the regular patients, but you can use that time. So that was extremely helpful. We had to change the bylaws to be able to credential TCM practitioners. So that was a big step, took a long time. And how do you peer review when none of us did acupuncture? How do you do peer review on acupuncturists? Well, thankfully there was already a credentialed acupuncturist who was there for treating drug addiction. And so we were able to use that individual to peer review the rest of the acupuncturists. Had he not been there, we would have had to hire somebody from the outside to come in and do peer review. We had to overcome physician reluctance. Again, everybody at Highland is Western trained, and so they, like me, were sort of ignorant about traditional Chinese medicine. So we had to train them, and Dr. Mateki came and gave grand rounds and presented some of the scientific evidence of the efficacy, the safety of doing acupuncture, and sort of made it plain that this was a viable alternative. And especially, as Western doctors, we're basically drug pushers, right? I mean, all we do is, here, you got a problem, here's a drug for it. And especially, there's a lot of side effects, a lot of problems with that. And so I think everybody's looking for something else, some other possibilities. And so this was an attractive possibility, I think, for a lot of physicians at Highland. How do you overcome patient reluctance? So this, again, was a matter of education. We put up posters around the hospital, both to advertise the service to the physicians, but also to the patients, that this was available. And that's how we overcame some of these obstacles. Our inpatient care began in 2011. This was one morning a week. We covered basically all the units, the wards, the ICU, the step-down unit, the emergency department, the Cancer Infusion Center, and OBGYN. And this was an amazing service because just like you could call a cardiology consult to an inpatient in the hospital, and the cardiologist would come to the bedside, examine the patient, review the EKGs, the echoes, et cetera, and make recommendations, you could call an acupuncture consult, and the acupuncture team would come to the bedside, examine the patient, review the history, etc., make a diagnosis, and deliver acupuncture on the spot. And so it was just incredibly versatile service available to all the patients. And we had a patient with renal failure one time who came in, and during his hospitalization, he developed flank pain, and we were like, what's this all about? It didn't appear to be musculoskeletal. We did a CAT scan. We couldn't find anything. And the acupuncturist service came up and consulted on the patient, gave him acupuncture treatment, relieved the pain completely. It never recurred. And it was like, wow, here's a way that we can we're treating the renal failure. They're treating the pain. And so working together to solve this patient's problem was a very powerful experience and something that was a great resource for anywhere in the hospital. And as I'll talk about in a little bit, we're even able to do this in the ICU. So outpatient service began in 2012, one morning a week, again, as I mentioned, in the K6 clinic. And generally saw about 10 to 12 patients per Thursday, approximately 600 patients a year. These are the diseases and pain symptoms that were treated on the inpatient service. So on the right are the symptoms, and on the left are the diseases. And you can see that most of it was pain. Usually, I can't even read this. The slide is so small, but you can, the big bar. Yeah, pain in various locations. And you can see on the green bars the diseases these patients had. It was anywhere from AIDS to heart failure, just a wide variety of medical illnesses that also concomitantly got acupuncture treatment. This is the outpatient clinic, and what the chief complaint was there was almost always neck pain and back pain, but there was also a scattering of other pains in the extremities and abdomen, various other locations. So in 2014, the Division of Integrative Medicine was created within the Department of Medicine. So this was a division. Amy was a division chief, and she came to all the division chief meetings along with the chief of the Division of Pulmonary and Renal and Hematology, Oncology, Pulmonary Critical Care, et cetera. And in 2016, she started the TCM internship program to bring students into the program as well. And because of this, she expanded the faculty, there were 8 volunteers originally, to 18 licensed acupuncturists practicing at Highland. In this residency program, we recruited TCM students from the local accredited schools in the Bay Area. It was a 2-year program with a very close relationship with the medicine team. There were didactics The acupuncture team rounded with the medicine teams. And at the time, I think we had 6 different medical teams taking care of the inpatients, in addition to a team on neurology, a team on nephrology, a team on cardiology, et cetera. And the students would rotate with each of these teams and round together. And so they would hear what the Western point of view was, what the Western diagnosis was, what we were doing for the patient from the Western point of view, and then they would make suggestions of what potentially acupuncture service could add to the service to care for these patients. So it was a very integrated program, and I think both sides benefited in terms of learning during this process. The faculty qualifications, you had to have a master's degree or higher in Oriental medicine from an accredited university, had to have a minimum of 5 years of experience, be licensed and credentialed, and of course demonstrate competency in HIPAA, bloodborne pathogens, et cetera, the usual requirements for inpatient practitioners. The training methods, as I mentioned, there was an integrated team approach for everyone, but they also took part in morning reports. So every morning, go with the other residents, interns, medical students, et cetera, hear about the cases that came in the night before and the medicine point of view, the Western medicine point of view. Go to noon conference to hear didactic presentations on various subjects that was being discussed. Grand rounds weekly, morbidity and mortality conference monthly, journal club monthly, and as I mentioned, inpatient consultation with all of the different subspecialties. So this was a great program. The picture here shows some of the students. We have a lot of classrooms, so the students are in the classroom getting a didactic presentation, oftentimes from one of the subspecialists. We'll talk about acute renal failure, for example, and then they would read articles from the Chinese approach, the traditional Chinese medicine approach to the same problem, and so again, sort of get evidence-based background on both sides of the equation. So we also wanted to do some clinical research, and this was a real head scratcher in the beginning because traditional Chinese medicine is very individualized, and each treatment is highly individualized to each patient. So how do you do research on something that's so individualized? So this was very difficult. I'm an ICU doctor primarily, and so I want to do research in the ICU. And in the beginning, I thought, geez, these patients are so sick, nobody's going to be a candidate for acupuncture, and these patients are struggling to live. So first we did a Medline review to see, has anybody done any kind of acupuncture research in the United States in the ICU? And I found one article, and this was in 2012 when we were contemplating doing this, one article which basically mostly looked at the percentage of patients who offered acupuncture who accepted treatment. That was sort of the primary endpoint of this study. That was 41%. Remember that number. They did 64 treatments on 22 patients. They had one side effect. Somebody got dizzy, but no major changes in their vital signs. So we said, okay, can we do this? And we chose pain and nausea and vomiting to be the symptoms that we wanted to treat, because these were sort of the most common symptoms in patients in the ICU, and these were things that acupuncture had been proven to be effective in terms of treating. So could we do that? Would the average American patient be receptive to this idea? Could it actually lower the requirement for pain medication? In other words, would it help them with the pain so that they didn't use so much morphine? And again, how do you standardize research in something so individualized? So our goal was to explore the feasibility of performing 3 acupuncture treatments over 3 consecutive days as adjunctive treatment for pain and or nausea and vomiting within the last 24 hours. All patients received standard care, so everybody got the usual care they got, but if they agreed to participate in this study, they would also get acupuncture. What were our inclusion and exclusion criteria? Well, our inclusion criteria, you had to be an ICU patient. You had to have nausea or pain within the last 24 hours. You had to be likely to stay in the ICU, stay in the hospital at least 3 days, because we were planning 3 consecutive days of acupuncture treatment. You had to be alert and oriented because you had to give consent, so that was a big item. What were our exclusion criteria? We did not treat anyone who was pregnant, any kids, anybody who had low white blood cell count, low platelets, or coagulopathy. So if they had a bleeding risk, we wouldn't do that. If they were on therapeutic anticoagulation, we wouldn't treat them. If they had a major active psychiatric disorder, we did not treat them. And if they were immunocompromised, we would not treat them. So how did we evaluate this? Well, we did a pain and nausea survey. So we did a pain assessment before treatment, and we used both a numerical pain score and a visual pain score, the little smiley faces, right? And we assessed nausea by using the Rhodes Index, which is a validated 8-point tool for a patient's assessment of nausea. And we did a pre-survey, which was administered by the acupuncturist before treatment. And then after treatment, the RN did a survey immediately after treatment, unaware of the results of the survey that had been done by the acupuncturist previously. And then finally, at the end of the treatments, the end of the 3 days, the RN did a final survey, again, not aware of the previous 2 surveys. What did the acupuncturist do? Well, they came to the bedside and did their traditional Chinese medicine thing. So they started with the 10 questions, which were the patient's perception of body temperature, sweat, sleep, energy, memory concentration, appetite digestion, thirst, urination, bowel movements, and mood. Then they would do a general physical exam, including the vital signs. They felt the radial pulse in both arms, examined the tongue, and then they identified the excesses or deficiencies based on traditional Chinese medicine diagnoses. We did not individualize the acupuncture treatment for each patient. We used the same points for everyone. And basically we used 4 points in the ear, the Shen Men, sympathetic, stomach, and thalamus. And then we used 4 points in the extremity, the large intestine 4, the liver 3, the pericardium 6, and the stomach 36 in the most accessible extremity. What were the outcomes that we looked for? The primary outcomes were the proportion of patients who were offered acupuncture who accepted it. Remember, that was 40% in that previous study done by Ye. Patient perception of the effects of acupuncture treatment, and the incidence of adverse effects related to acupuncture. Our secondary outcomes were the dosage and quantity of analgesics and antiemetics used before and after acupuncture treatments, the TCM diagnoses, frequency and patterns, and the effect of treatment on vital signs. So this was a feasibility study. So between November of 2014 and April of 2015, all patients in the ICU were eligible. So this included medical patients, surgical patients, trauma patients, neurosurgical patients. Everybody was eligible. This was sort of the study design. So the acupuncturists and the nurses would get together between 7 and 8 a.m. in the morning. And they would identify who they thought was potentially a candidate for acupuncture. We would then contact the attending physician of record and ask them, are you okay with this? Okay, and nobody refused. And then we would ask the patient for consent. And if they declined consent, they would get the usual care. And if they agreed to treatment, then they would get usual care plus all the things that I mentioned, which I can't read from this slide, but they would look at the vital signs, the TCM diagnoses, the patient's perception. The patient had to have pain at the time to be eligible for the study. And then we would do a chart review of the medications the patient had received, the vital signs, etc. So what were the results of this? Well, 46 patients agreed to have acupuncture, day 1. Day 2, 8 patients had dropped out, 4 were discharged, 2 declined, and 2 had altered mental status, so they were too out of it to be able to agree to the treatment at that time. Day 3, 30 patients received acupuncture. Again, 8 dropped out, 4 were discharged, 2 declined. 1 had altered mental status, and 1 got so sick he was no longer a candidate. Overall, the average self-reported pain level immediately following acupuncture decreased by a mean of 2.36 points on the numerical pain scale over all 3 days. And this was statistically significant. Anything over 2 points is considered an appropriate positive response to any analgesic given. 77% of the patients reported that acupuncture helped them, and 84% would recommend it to other hospitalized patients. This is sort of a look at the pain scores before and after acupuncture on day 1, day 2, and day 3. This is the morphine dosage. So we looked through the medication administration record and recorded all of the opiates that the patient had received over the 4 hours before each treatment and the 4 hours after each treatment. And this included oral opiates, IV drips, and boluses, and everything was converted to morphine equivalents and then averaged over the 4-hour period. And after each acupuncture treatment, the dosage of morphine decreased, and this was significant. And I'll talk about some of the limitations in a minute, but this was significant. The patients with nausea also mostly had a decrease, not on day 2, but on day 1 and day 3. Acupuncture seemed to relieve the symptoms of nausea as well. These were the TCM diagnosis results, and again, I'm going to need my glasses on this one. It was the excess pathologies were mostly blood and qi stagnation, and the deficiencies were mostly qi deficiency. But you can see there was a widespread of other TCM pathologies that were found. All in all, 933 needles were inserted. So a pretty big number, only 7 fell out. Again, the needles were put in and kept there for 20 minutes. If they fell out, they were not reinserted, and so only 7 fell out. I think this is the most important slide, the most important finding of our study. Most acupuncture recipients in the United States are female, highly educated, and Asian. 77% of our patients were male. 60% were African American or Hispanic, 50% had a high school education or less, and 68% were acupuncture naive. So this was incredible that a wide variety of patients were very accepted and appreciative of acupuncture treatment. And I think future research really needs to use a much broader patient population to make people understand that this is applicable to a very large group of patients. It's applicable to everybody. It's not just people that are highly educated and have private insurance, et cetera. So I think this was probably the most important thing that we found. Limitations of the studies for the pilot study only. There was no control group. There was no randomization, no blinding. Only 40, it says 47, should be 46 patients. So you can't draw any conclusions regarding effectiveness. It was single center. And although we were looking for a decrease in pain and the use of analgesics and antiemetics, patients presumably get better spontaneously over time, right? So maybe they just got better on their own. And we try to mitigate against this by looking at the 4 hours before and the 4 hours afterwards, so sort of a limited time period, so hopefully patients wouldn't recover that quickly, and that therefore we could assume that the beneficial effect was due to the acupuncture. So conclusions, it is feasible to provide acupuncture treatment in the ICU. Almost a third of all the ICU patients in this study were felt to be appropriate candidates by the ICU nurses. This was astonishing. Like I said, when we thought of doing this study, I walked around the ICU and said, my God, these patients are sick. And at Highland Hospital, let me tell you, they are sick. And we do acuity scoring using Apache 4, which is a thing that looks at acuity. It's the best scoring system in the world for that. And the patients at Highland are sicker than patients in ICU in other ICUs nationwide. So I thought, this is no way we're going to find enough patients to be eligible for acupuncture. But that did not turn out to be the case. 30% of people were. Almost 10% ended up receiving it, and 97% of the needles were retained. Most patients found their acupuncture experience positive, and over half self-reported an anxiolytic effect, which is not something that we were looking for, but the patient spontaneously reported it, and this has been described in other studies of acupuncture. And so this is something, an extra beneficial effect, and anxiety, as you might imagine, contributes to discomfort and poor outcomes in the ICU. There were no significant adverse effects. Vital signs, I didn't mention that, but we did look at the change in vital signs. The pulse and blood pressure went down like one point or so, but it was not statistically significant, though it certainly didn't go up. So acupuncture appears to be a valuable adjunctive therapy in the ICU and merits further study, particularly in a broad population, as I mentioned. So in 2019, Alameda Health System faced a multi-million-dollar deficit, and every department was required to cut services. Unfortunately, the Department of Medicine elected to eliminate the Division of Integrative Medicine. This was a horrible decision, very short-sighted. I did my best to prevent this from happening, but unfortunately I was unable to. And so Dr. Matecki had to start all over again and move all of this to the private sector, to Alta Bates Hospital, and deprive all our Medicare patients and patients without insurance and people who don't speak English and, et cetera, and go to the private sector. So again, I think this was a very short-sighted and very poor decision, but unfortunately the county is limited by finances, and a lot of times decisions are made by people who are not on the front lines of patient care, and so this is what happened. So Amy's going to talk about her experiences from there, where she's gone from there, but that's what happened at Highland. So I'd be happy to entertain any questions. Yes? So, when you do acupuncture, you leave the needles in for 20 minutes, but if the patient moves around or gets agitated or whatever, sometimes the needles fall out. And I guess, I don't know, I'm not an acupuncturist, as I mentioned. Maybe somebody can help me here. Sometimes people reinsert them. Amy, can somebody help me here? Yes, Talbert, thank you.
I knew Colin when we both had black hair.
Yes. that was 3 years ago.
The Chinese have done a lot of research in acupuncture.
Yeah.
They've proven that, one, you increase the alpha wave, which is the slow wave, 8 to 12, which causes relaxation.
Yeah.
They did a study in a cat, where they did the needles in the cat, and the cat started going to sleep. So they've done a lot of research, like acupuncture will increase 5-hydroxytryptamine, which increases serotonin, and they did studies that showed that it worked through the nerves. For instance, if you did the acupuncture on a patient with hemiplegia, it wouldn't work. They also did studies that proved that it did not work through the blood flow, because if you tied off the blood arteries, the acupuncture did work. They did studies that proved that it works in the deeper muscles and not the superficial muscles. I got involved with acupuncture, I'll talk later, when I went to China with the Black Panther Party, but there was a lot of research done which Western doctors were not interested in. They're still discriminating against acupuncture. Mr. Barty Lynch had to sue the government to get them to pay Medi-Cal. So what do? They give you 2 treatments a month, and they don't pay you enough to meet your overhead. I used to be the first acupuncturist for Hill physicians. Hill physicians didn't want to do acupuncture. Okay, I'm told to shut up. So
Okay.
go ahead.
So,
Question, please get the mic so that the people on the YouTube can hear your question.
I do want to get an answer to the question. So some of the acupuncturists here, can you tell me if the needles fall out during a session, do you reinsert them or not? No. No, but would you reinsert a needle to the same site if one fell out, normally?
Would you answer to the microphone, please?
It would be great if you stand up and I'll hand you a microphone if you're answering a question.
Here's Dr. Joe.
Yeah, my name is Joanna Chow, and acupuncturist. Yeah, for the needle insertion, you have to see if the points is very important. After the needle fell off, it's not often, just like Dr. Feeney just talked about. Sometimes you move around. And also, sometimes the points, you have to talk about the qi. The energy is already enough. The needle, the body will push the needle out. That's, you will see it, yeah. So that time, you don't need a reinsertion. Yeah, you don't need it. If it's a dropped, if you put two superficial dropped, and you have to change another needle. You can't use original needle to insert. Okay, thank you.
Thank you for answering that. Yes, in the back. Yes,
Let's
sir.
get you a microphone. Stand up.
You,
Someone-
sir.
Hand up.
This is Philip Yang. I'm practitioner of acupuncture for 25 more years. I was one of the initial participants in Helen Hospital for some time in this program. For the falling needles, yeah, just like Dr. Joanna said, it depends how important the point is. For some of the points, like I also counted the time, like after 10 minutes, if the needle falls, I won't need to reinsert. But if it is a very, very important, need a more repeated stimulation, I need to reinsert. Like for insomnia patients, I insert the needles for the auricular needles for shaman, and that need more stimulation, so I'll reinsert the needles. It's very, very easy to fall because it's very, very superficial. But for the other points, like the body needles, I may not re-enter. So long as I have the substitute needles to take the Qi and effect. Thank you.
Thank you. So again, this is part of the individualized treatment that acupuncture is so famous for. But in this study, we had to standardize it. So basically, we decided ahead of time that the protocol was going to be, if the needles fell out, we would not reinsert them. Yes, sir.
Thank you. I'm a physician from California North State University, and I'd like your comments on a hypothesis I have. It's not mine. It's not new. It's not original. But I'm thinking the people drawn to healing are different, and in the interaction with patients, there's that human factor that we all know about. They call it the placebo response. I call it the healing response. How much of that do you think plays into these wonderful positive results from your research?
Again, one can't, that's one of the limitations of potentially of the study. And again, the acupuncturist spent on average 30 to 45 minutes with each patient taking the history, examining the patient, and performing the acupuncture. So was that extra time spent with the patient? Did that contribute to the salutary effects? Was it that so that could have been part of it too. Again, this is the problem with a non-blinded, non-randomized study. This was a feasibility study, not an efficacy study. There certainly could have been that component may have played a role. So I don't know the answer to that question.
But in your experience, do you find the same thing? I'm thinking the nurses that were all acupuncturists, they're different from other nurses, perhaps,
Well,
from their way of being present in the world.
Well, the acupuncturists weren't nurses, right? So that we had the regular ICU nurses, but they were whoever was assigned to the patient. So they weren't necessarily either pro acupuncture or against acupuncture. They were assigned to the patients, and usually often be the charge nurse that would go around and ask who is anybody potentially a candidate. Mostly we're looking for people that were awake, alert, and again that's not a big number in the ICU. Yes.
Okay, I just want to add during that acupuncture research, so when initially our acupuncturists do the intake, like check their scores, like nutrition, the pain scores, but when finish the treatment, they are not the one assess the patients. Actually, it's the nurse stepping in to assess. We just try to remove the biases.
Right.
But we do the best that we can. Of course, this is not placebo controlled. There is definitely some kind of the possibility bias into it.
Yeah, the nurses did all the post-treatment surveys, and they did not know the results of the pre-treatment surveys.
I just wanted to point out, I think there's a cool study led by Ted Kapchuk on this concept. about like the placebo effect and how that affects healing, or is a possible the interaction with the acupuncturist or the doctor, how long they spend time with them, like the healing effect versus placebo effect. It's pretty cool. And I think I read it a long time ago. It's based out of Harvard. Ted Kapchuk, he's a pretty cool acupuncture guy, so worth looking at.
I just wanted to mention that for anyone that's really serious about understanding placebo, I just wanted to suggest that some research is done in veterinary hospitals. If you've ever witnessed a dog or a cat receiving acupuncture, the immediate both relief and relaxation that they experience is not happening because the dog or the cat believes that the acupuncture will work.
My roommate had a St. Bernard who had terrible arthritis and couldn't walk, and he got acupuncture and walked well after that, so I'm with you on that.
Hi, Doc. Thank you so much for your excellent speech. I'm Dr. Hong Mei Ni, represent California Acupuncture United Association. I'm a president of CAWA. My question was, in ICU, when you treat patient, do you use any herbs for ICU patient, please? Thank you.
Not yet.
I would just like to say that I am a veterinarian who's been doing acupuncture with animals for 45 years. And the placebo effect is quite minimal. You can look at the animal, and very often we do, and say, okay, this will help you. And the animal will say, okay. But a lot of times they don't. So it's not so much a placebo effect as a neurological effect, as well as the traditional reasons that acupuncture helps humans.
All right. Thank you very much. Thanks.